So now we would move to the talk by Dr. David Chang, which everybody is awaiting. And pleasure to have you, David, here. And I would now request you to please give your talk.
All right, well, it's so nice to be with you today, and I'm honored to give this talk on a very important topic of surgical antibiotic prophylaxis. I have no financial interest in these topics. We know that intracameral antibiotic prophylaxis is a controversial topic. Those criticizing this will point to some of the risks, mixing error, inducing bacterial resistance. How long does the drug really stay in the anterior chamber, and is the cost justified? And we had an interesting counterpoint, a letter to the editor from Bascom Palmer, and then our response, along with the Aravind co-authors of our paper on intracameral moxie, and then Dr. Harapriya, who I'm so pleased is on as a panelist. We have done reviews on this recently, if you want kind of an update. If we look at the practice patterns in the United States, the last time we did a large survey from ASCRS, we found that intracameral antibiotics went way up compared to 2007. Majority of this was direct injection. Most people now do not put it in the bottle any longer. And this was a large a number of ASCRS international respondents. And we can see it's about a third divided between moxie, vancomycin, and cefuroxime. If you looked back in 2014, just at Americans, though, more than half were using vancomycin, and that was the most popular by far. The concern with vancomycin in the past was, will we ruin the efficacy of this important last line of defense by getting drug resistance? But here are two papers explaining why that is quite remote, because of the fact that we really don't have much bacterial load in the anterior chamber to induce resistance. And actually, the best human pharmacokinetic data is probably this study from Liverpool, published in 2007, in which they followed and actually went back and withdrew aqueous from patients that received 0.1 ml of vancomycin at the end of the case, and showed that it exceeded the MIC for at least a day and a half. So it took much longer to clear than you would have predicted from rabbit eyes. But of course, all of the use of vancomycin has dropped precipitously after HORV, hemorrhagic occlusive retinal vasculitis, became known to us. This was the initial report of only 6 patients. And after that, I co-chaired a panel with the American Society of Retina Specialists, where we really sought to study just how often this occurred and what it was due to, and whether it was really vancomycin, given that that was our leading intracameral antibiotic in the United States at the time. So this was our paper in which we found and published 36 eyes that the retina specialists all agreed were HORV. 13 were bilateral, and every single one of these eyes received vancomycin intraocular in one way, shape, or form. There was actually 9 additional eyes, which would have brought us to 45 that were likely HORV, but because we didn't have good photographs, we couldn't be absolutely sure of the diagnosis, so they were not included. But this, unfortunately, is a delayed onset. So often the second eye is already done before the first eye manifests this. And it's due to intraocular vancomycin. The second eye onset is earlier and it's more severe, consistent with a hypersensitivity. And if they got a second dose because of feared endophthalmitis, it had the worst prognosis. So you can see here the right eye was done first, and then the left eye was operated on second. And so there was a much stronger reaction in terms of occlusive peripheral vasculitis. The outcomes were very poor in these groups. Only 17% regained reasonable vision. More than half went on to develop neovascular glaucoma. And I mentioned that some of the eyes, because the suspicion was endophthalmitis, actually got an intravitreal vancomycin dose, and they did terribly. 5 out of 7 were NLP. So we concluded that this was an immune reaction that fit what's called a type 3 hypersensitivity because it's a delayed onset, it affects the veins. And there is actually precedent for a type 3 hypersensitivity to vancomycin systemically. It's called leukocytoclastic vasculitis. And the problem is then it's a delayed onset, so the second eye gets it before it's diagnosed. And this is not something we can test for in advance. So the most recent Academy PPP basically discouraged the use of vancomycin because of this blinding complication. And furthermore, the US FDA, in reporting a bilateral case, this is when moxi and vancomycin were injected transzonular. They again strongly discouraged this. And from a medical legal standpoint, this sort of makes it untenable now, most of us believe, to use vancomycin. We still only have the one landmark randomized trial from ESCRS in which they compared intracameral cefuroxime with or without a topical fluoroquinolone. And this study result has been borne out in multiple large national retrospective studies over the years showing the efficacy of cefuroxime intracameral. This, of course, really is the only good evidence that any type of antibiotic prophylaxis works because things like topical antibiotics, again, the evidence is weaker. Certainly povidone, iodine, the evidence is strong. But ESCRS, based on their randomized control trial, really came out with a strong recommendation to, in this case, use intracameral cefuroxime, which is available in many European countries through the French pharmaceutical TEA. And from that, we know it's got a very impressive safety record. The Cochrane database looks at quality of literature, and not surprisingly, again, they cited the one randomized controlled trial. But they really came up with the proper conclusion, which is this is something that's rare. So to really do a randomized trial, you would need an incredibly large study that was very costly and probably impractical. And so really this is a situation where we have to rely on other forms of evidence to make the best decision about prophylaxis. This is a very important editorial by John Javid in Ophthalmology. And he also talked about the difficulty of a randomized trial. Would it be ethical not to treat some people? It would have to be so large and so expensive that would that make the resulting FDA-approved product too expensive to use? And wasn't there already enough preponderance of evidence? So again, you'll hear from Dr. Harapriya as well, who was delighted to be able to collaborate on a number of studies done at ARAV. And this was the first, and it was in that same issue of the Javid editorial that this was published. And this was looking at manual small incision at one Erevin Hospital, Madurai, a little bit more than a year's time. And I think the advantage of this is that in just a year's time, essentially you know that nothing else was changed, just the routine use of intracameral moxifloxacin. And there was a very strongly significant reduction in endophthalmitis. So this is just showing the numbers, very large numbers in roughly a year's time, 30 cases dropping to 6 cases. And this was using the Oramox from Oralab, and this is approved for intraocular use in India. So we concluded that in situations where there was concern about certain practices like multiple patients in an operating room, but certainly in our camp outreach settings where conditions are less than ideal, this is such an inexpensive method, and we showed the value of it in the manual small incision. The data was strong enough to then convince the leadership at Aravind to institute this in all cases at all of their more than 10 hospitals at the time. So by the time we got to 2.5 years, we published that data here in this study in ophthalmology. And we continued the study till we had 8 years of data, and that was 2 million surgeries, 1 million consecutive with intracameral moxifloxacin. And this was published just a year ago. Now, this is an impressive graph because every single one of the bars is a 3-month period at all of the Aravind hospitals. So each of the blue bars is without antibiotic. The orange bars are with routine intracameral moxi, and the yellow bars are during that transition period of about a year when one at a time different centers would transition. So during that year, some of the cases were done with and without intracameral moxi. And you can really compare any of the blue bars and any of the orange bars and see that it was statistically significant. And then look at the massive numbers, 69,000, 72,000 in just one quarter. So to put this in perspective, the entire ESCRS trial was only 16,000 patients. And so this gave us the 2 million. With the rate dropping from 7 per 10,000 down to 2 per 10,000, and this was out over an 8-year period. So if we look at these 2 million cases, again, this is without 7 per 10,000 dropping to 2 per 10,000. Now, what's amazing is that in the United States, our rate is 4 per 10,000, and this is good data because we can pull it from the Academy's IRIS registry. So it's higher than it is at Aravind, despite the fact that as part of their mission to be efficient and cost effective, they reuse many supplies and do all sorts of operating room practices that we're not allowed to do in the United States because of what? The risk of infection. Now, if you look only at manual small incision, the superiority, the efficacy is there. It's even more obvious with phaco. And what was interesting with this many patients is we were able to get a large number of people who had posterior capsule rupture, even though their rate was still less than 1.5%. We have more than 28,000 cases with posterior capsule rupture. So now if you look at them when you did not use an intracameral antibiotic, the rate jumps 7 times from 6 per 10,000 to 43 per 10,000. So losing the posterior capsule is a barrier. With or without vitrectomy, the rate of infection goes way, way up. Now, what happens with the group that routinely got intracameral moxi is a similar number of patients. So the rate still goes up. It's low, and it goes up to a higher rate when you break the capsule, even with intracameral moxi. But you can see that the rate is less than half in terms of when you have that complication without intracameral moxi. So one of the conclusions was, even if you're not going to do this routinely, if you break the capsule, do a vitrectomy, you really should use intraocular antibiotic at that time. We can talk about why it is that the rate is still high here, but we have to consider that they were injecting 0.1 ml of moxi into the anterior chamber. And once you do a vitrectomy, the concentration in the eye now is much, much lower than it would be in an uncomplicated case. And perhaps it was really underdosing in those cases. Now, we also looked at routine cases that were uncomplicated because one could wonder, is the efficacy really all because it works so well in complicated cases? So these are uncomplicated cases, and you can see that the rate is still maybe 4 times lower when you add intracameral moxifloxacin. With phaco, it was 6 times lower looking at phaco alone. If there's reoperation, such as a secondary IOL, again, the rate is much higher in terms of endophthalmitis. Intracameral moxi lowers it. And again, many of these patients did not have a posterior capsule. If you look at the world's literature, the importance of these Aravind studies really, number one, it's because for moxifloxacin, it's the best data. But number two, when you do retrospective trials, of course, the concern is how many other things were introduced that are variables that could have also affected the endophthalmitis rate. And so you want to have a lot of cases in a short period of time. And that's what was shown here. And then, of course, now it's just large numbers of data and just the largest cases. So if you go back to the Cochrane review, randomized trial, you're doing a randomized trial because you're trying to isolate just the one variable, intraocular moxifloxacin. But as I showed you, the Aravind data shows whether you look at just 1 year at one hospital, you look at 2.5 years at all the hospitals, you look at 8 years all across the hospitals, the numbers actually didn't change. And there's basically a four-fold reduction in endophthalmitis, and it's lower when you do phaco. And beyond what we are achieving in the United States with all of the expensive regulations that require throwing everything out after a single use. So I think it's the best evidence we literally have now regarding efficacy. And, of course, this also provided safety data as well. This is an in vitro study, which is very interesting because they looked at models and compared the three drugs for intraocular. And one of the things they point out is that resistance is really, even if you have resistant organisms, these drugs work because of the very high concentration. To determine that an endophthalmitis isolate is, say, resistant to moxifloxacin, you look at the the 90% kill rate, the MIC 90, and then you look at a chart and you see what's the systemic level that's usually achieved in the bloodstream by oral moxifloxacin, and then you decide, based on that, it's resistant. But what that doesn't capture is what we're doing in the eye, which is injecting a huge concentration. And so when you look at data that says this isolate is resistant, you got to realize it's tested not really in the same context. So they concluded that Moxi and Vanco were among the best. Now, if you look at this study at Aravind, without intracameral Moxi, there were 43 coagulase negative staph, and less than 2/3 were sensitive to Moxi. So more than a third were resistant to Moxi. So you would expect then, well, does that mean that we didn't really affect that with the intracameral Moxi? And yet we did. We dropped this, basically more than 8 times lower. And that's the effect of the very high concentration, therefore. This was a recent meta-analysis published 2 years ago, looking at all the studies over 2 decades. It included the 600,000 publication from Aravind. And this is just showing that on a relative basis, Moxi and Vanco were the most effective agents in terms of efficacy. But they concluded that all of them had minimal toxicity at standard doses, that Moxi kind of had the best safety record and had a low toxicity profile at all of the concentrations. There was one randomized controlled trial that was published from Brazil that showed efficacy with moxifloxacin. This was a little special, though. This was looking at residents at 3 hospitals, and we know residents break the capsules. So that's why in a small number of patients with probably a very high complication rate, they were able to show in a RCT that Moxi was more effective. But you can see that without Moxi, their rate of infection was extremely high. It's almost 40 per 10,000. So I'm not sure what was going there. It must have been a very high complication rate, which was about 8%. We know in the United States, probably the reason we don't have numbers like Aravind's is the fact that still about half of the American surgeons don't use any type of intracameral or intraocular antibiotic. So this is from our 2019 ASCRS survey. But of those that do, moxifloxacin is clearly in the lead, and vancomycin, you remember from 2014. 5 years earlier, vancomycin was more than 50%. So that reflects HORV. And if you look at US versus international, this is international respondents, again, reflecting where cefuroxime was available in Europe and the Middle East, was more commonly used. And then this is a study that we published last year, also done at Aravind, where we did a randomized trial, but bilateral, where one eye of a patient got a higher dose, one got a lower dose. And we actually looked at endothelial cell counts and found that there was no difference. So therefore, the higher dose, which was being used, appears to be just as safe. And of course, if they're equally safe, use the higher dose would be the logical thing. This is looking at how we do this in the United States. Now, we use Vigamox because it is unpreserved. You have to be careful because none of these bottles were formulated for intraocular use. We have to be sure that there's no contaminants or anything there that could cause a TAS. So a generic topical moxifloxacin in the US does cause TAS. But these are some of the papers that show the safety here. Many of us use moxifloxacin compounded by pharmacists at either the higher dose on the left, that's what was used at Aravind, or a lower dose. Steve Arshinoff has sort of published his formulation in which he dilutes it, but then injects a larger amount because he wants to be sure that you get the full amount. So there's basically three ways to get this dose. And what we're really trying to achieve is about 1,000 micrograms per ml. You figure that the aqueous volume in a standard size eye after the IOL is about 0.5 ml. So you can get that 500 micrograms either by 0.1 ml of Oramox or Vigamox. This is Arshinoff injecting a larger volume of diluted. And for those of us that use 0.1%, you're doing basically an entire aqueous exchange, trying to achieve that similar method. So if you go back to this survey, why are people not injecting intracameral in the United States? The number of people that aren't convinced that it works had dropped by 2014. I think nowadays that's even much lower. So really, for many people, it's the risk of TAS from mixing. Again, from this survey, 85% said they would use an intracameral antibiotic if it was available at a reasonable cost. I think that number would be much higher now. I just will just make one comment. We did a survey of cataract surgeons' attitudes towards OR waste that was just published this year, and my editorial is in this month's issue of Ophthalmology on waste in cataract surgery, where the overwhelming majority of people felt that trash was excessive. We ought to reuse more things. 10 times as many surgeons preferred a reusable instrument than a disposable if of equal cost, and really asking for more discretion to reuse things being left to the surgeon. This was certain supply items that people were either currently or willing to reuse, blades and retractors. And it was interesting that many were willing to or already were not using a full body drape, not having the patient change. Not as many were willing, however, to not change gloves or gowns in between cases. And Dr. Harapriya has done a study due to COVID requiring certain changes at Aravind. And this is, again, across their system where the patients now are being changed into gowns. Only one patient at a time was in the OR, and the surgeon and the staff were changing their gloves. And you can see during these time periods, very large numbers. And so the question was doing these things which are instituted for viral transmission, did that also lower the endophthalmitis rate? And the answer is it did not. And we're working on a public that. So with that, I'll thank you for your attention, and I look forward to the discussion.
So thank you, David, for such an extensive talk. I think nothing was left after your talk to talk about intracameral moxifloxacin, which is still the hot topic today. And thanks to the contribution from Arvind Eye Hospital, Dr. Harpriya Arvind, as well as Dr. David Chang, who've just changed the way we now do, way we now tackle with prevention of endophthalmitis. So I believe there was a study which was started by ASCRS, or was to be started by ASCRS, where they wanted to do a very large randomized control study. I remember about a year ago. And has that study started, or is it in pipeline, or what is the status of that study?
Yeah, we still haven't studied it. This is so expensive that we're trying to get funding from the National Health Service called the National Eye Institute, and we're still working to try to find a manufacturer that will go through everything, because this study would certainly solve once and for all whether this works. It's an RCT. And the problem is that we would need about 75,000 patients randomized, which is just a huge number. And the question is how to pay for that study. So no word yet on whether we can actually pull it off.
So, there were, you are absolutely right, randomized studies are not required, and we have initiated a randomized control study at our center, which is RP Center, and it is a tertiary apex institute at Delhi. And we have recruited about 7,500 patients already, and because of the COVID, it took a little setback. But I'm sure it'll pick it up again after the COVID thing, subsides. And just to say about the various formulations available with the Cipla company, the sponsors company, we do have moxifloxacin singules available. So just like unims, you can, actually use them intracamerally as well. So that was one thing which is preservative free.
What's the
So
concentration of that? Do you know?
yeah, it is the same as Vigamox from,
Vigamox?
yeah, same concentration as Vigamox.
Mhm.
So, Rajesh, do we have any questions on the moderators panel, or the panelists would want to comment, Dr. Arup?
Yeah. So, David, as usual, it was a wonderful presentation and very few doubts left. But I have one question for you. We still have people who tell us that we have been perfectly happy with the post-op outcome. We have not had any endo cases for the last 10 years, and we have not been using intracameral antibiotics. So, what would be your answer to them?
Well, I think that this comes in waves, and it's a sporadic thing. And I think this is where big data uh, helps us. You need large numbers to capture, an incidence of something that's extremely rare. And whenever you look at all the studies with big data, it's like 19 will show an effect and one doesn't, type of thing. And then, so I'm talking about all the large randomized trials that have been, I'm sorry, all the large retrospective trials that have been published throughout the world. So unfortunately, none of us in our own practices in our own hospital can see data of that size. And that's why having this electronic record at Aravind is so valuable. And, perhaps I'll ask Dr. Harapriya to comment, because they not only do they see the numbers, but, endophthalmitis still sticks out to every cataract surgeon. And I think their impression was pretty decisive when they saw the trend.
Yes, yeah. Thank you again, David, for that excellent talk. And as you said very early on, so we started on the camp and free patients because endophthalmitis was higher with the SICS technique. But we saw the effect so early. So that's where I think David was visiting India for the APACRS meeting, and then we discussed this, and that's when the first paper came out. But the difference was so obvious, we just rolled it out to all our hospitals and the phaco patients as well. So I think the intracameral moxifloxacin, one reduces endophthalmitis, but it also kinds of makes it a little less aggressive, less severe. So especially most of the endophthalmitis we see, of course, is sporadic, but there could be instances when you could have a cluster as well. It could be things like you have some high endotoxin level with some consumable which we use. And we have seen that not just endophthalmitis, but even our incidence of postoperative iritis, inflammation, which we would have, some patients would come back after 2 or 3 weeks after surgery. That is also definitely reduced after we have used intracameral moxifloxacin. So it's probably effective in different ways. And those who are where we do have the endophthalmitis as well, the culture, most of them are culture negative. It is more sterile, but we label it as endophthalmitis because they might have received a vitreous stab, and the outcome also is definitely better. So I think it makes the infection also less severe. So since we are seeing the benefit of use of this practice, we have made this mandatory in all our hospitals. All intraocular surgeries today, we give intraocular intracameral moxifloxacin.
I just want to say one thing in continuation with what Dr. Arup said, because there's people who don't advocate this thing. They say that there are a couple of studies which have shown that, you know, when vancomycin was used in bottles, there was some increase in the retinal edema. So if you say that there's a PCR and you inject a intracameral drug, so I mean, the whole eye is a single chamber now. So will the chance of retinal edema increase if you are putting anything inside the eye, if there's a PCR?
And before Haripriya takes over, another question for Haripriya. Did you feel that there is some sort of an anti-inflammatory effect of intracameral moxifloxacin, reduce flares, cells, pigments, etc. in second or third post-operative visit?
Yeah, not in the immediate post-operative period. That I think that does not really matter. But we used to have some of our patients, like say about 1% of our patients used to come back a little later with late iritis, especially when we use HPMC and SICS large tunnels. So some of them used to come back with iritis inflammation at 3 weeks post-op, but we used to taper the steroids. That has reduced drastically. So I think that probably was a milder form. There was some endotoxin in the eye which was flaring up once the steroid dose came down, and that I think the moxie is also taking care of that. Yeah, so that probably is helping in the inflammation as well.
There was another thing that I just wanted to say. In Science report, if you see 2019, there is a study on, in vitro effects of moxifloxacin and vancomycin and cefuroxime, where it did show in vitro that moxifloxacin is toxic to the retinal vascular cells. I don't know if, so that was a little, surprising that it showed that. Maybe clinically it doesn't manifest, but in vitro studies in Science report in 2019 article did show it.
Namrata, I would like to say that even for management of endophthalmitis, we do give intravitreal moxifloxacin. So it's not really toxic, and the dose is also 200 to 400 micrograms. So this would not be toxic. So, okay, in vitro, it might have been shown to be toxic, but clinically it is used
Yeah.
for
So
management.
yeah, that's what I think. Maybe that is not, clinically manifested, only seen in vitro studies.
To answer Dr. Aroop's question, whether it can cause retinal edema, well, these antibiotics are not known to cause retinal edema whenever we use for intravitreal indications. In themselves, they do not cause the edema.
I just wanted to add another point. I mean, we tend to get overwhelmed by intracameral moxifloxacin. At the same time, we must not disregard the existing, the practices, the sterile precautions. I think Dr. Savitri Sharma is going to cover all those areas. So it is not to say that, you can rest assured that if you, whatever you do in the theater, your sterile precautions, adhering to them, they have to be done. In addition to that, you have to use intracameral moxifloxacin. Just as an anecdote, David, we started our new theater about a year back, and I was not using intracameral moxifloxacin all these years, in spite of all the evidence and whatever, because of the reason I mentioned earlier. So we decided that now it's a new setup. Should we bring this in? We sort of decided not to bring it in because we didn't want to change anything that was happening earlier. So this is where I stand today.
How about you, Chitra? Are you using intracameral moxiflox for all cases or only for complicated cases?
I use for precedent situations. Whenever we do vitrectomy, I'm talking about routine catheter situations. I've not yet started. Chitra.
We do the same, if I can just say before Chitra.
Chitra?
We have a list. Can you hear me?
Yes, ma'am. Yes, ma'am.
Yeah.
We have a list of high-risk situations in the OR, and our surgeons go by that list, and only then they give. Not for all patients.
As a very theoretical question, if I've also felt what Haripriya said, that giving intracameral seems to have some kind of an anti-inflammatory role, in the sense eyes are so much quieter. Of course, it's n number of features involved, the kind of surgical skill which we have now and the parameters which you use. But if you've had a PCR, would you wonder increasing the dosage of moxifloxacin primarily, or would you even think of giving a repeat intracameral if there is a mild inflammation after a vitrectomy? Does it make sense to go further thinking like that?
Yeah, so I think it does make sense, but we haven't yet, a few surgeons do it, but I think we need to probably understand more completely as to what would be the right dosing if we have vitreous loss versus without vitreous loss, if he plays an IO. So I think all those questions we need to clarify, but we are thinking on those lines to see if we can come up with something when we have a poster capsule tape. But I think, during the transition period, we had many surgeons would forget to give intracameral antibiotics after a poster capsule rupture. But once it became the norm and all surgeons used it for all cases, it definitely helped in eyes with complications. And the eyes with highest risk of postoperative endophthalmitis are eyes which go in for secondary sutured IOLs or like serial fixated, iris fixated lenses. So they are very high risk. So I think all secondary procedures also would also benefit if they receive intracameral antibiotics.
Another question for Dr. Haripriya and David. I mean, okay, what is the method of injection of intracameral moxi? There are so many ways it could be delivered in the anterior chamber. So what is it that you recommend? What is the preferred practice?
So, David, okay, any of you? I mean, both of
I'll
you.
go first. I'll go first. We are using the same concentration as Oromox, which is 0.1 ml. So I think when you do that, you have to make sure that your wounds are well sealed. You test that the eye is firm, and sort of the very last thing you do is you put your cannula in, you maybe burp a few drops out, and then you inject it in. The benefit is that what you put in, you know exactly that amount. Now, there are other people that use the lower concentration, and they like to inject, pull up, 0.3, 0.4 ml. And if you've ever injected into the eye, it takes a long time to inject 0.4 ml. And, they just keep injecting. Some of that washes out, but you're just, their feeling then is you assume there's some leakage, and you have that whole amount. I think most of us, we try to inject it toward the bag, toward the lens, kind of away from the cornea. Then you have the dilution, the toxicity would be that momentary, very high concentration. So I would just say don't aim it toward the endothelium.
Yeah. So this injection, the Oromox, which we're using, is ready to use. So it doesn't need any dilution. So we draw in about 0.1 ml of the drug, 500 microgram. We use a tuberculin syringe, and as David mentioned, we would form the anterior chamber where we'll hydrate the paracentesis and then inject it. Sometimes if you have a large side port like an SIC tunnel, you may not be able to go right into the back towards the IOL. So we find that we inject only at the tunnel into the anterior chamber. And that seems to work well too, because we have so many surgeons across the spectrum in training, surgeons who are experienced, and we find that this works in all their hands. So I think having it in the eye, in the anterior chamber works fine. So even injecting it at the tunnel makes sense, as long as we don't leave the chamber shallow after injection. So you want to hydrate the side port well and then inject this finally.
What about flushing the bag? I know some of my colleagues, they deposit the entire solution in the capsular bag. So
that I think is good if, like, as David mentioned, the Steve Ashnoff's suggestion of using 0.3, 0.4 ml. If you have a larger volume with lesser concentration, one could go do that, because you need that kind of volume to insert your cannula into the bag and then retract it. You have to have continuous fluid. With a 0.1 ml, that may not be adequate. So with having discussions with Dr. Ashnoff, we were considering whether we should move to his suggestion. But we realized our outcomes, I mean, our endophthalmitis rate in 2019, it was about 1 per 10,000, 0.01%. So we found the current practice is working well. So we didn't want to confuse all the surgeons and the operating room staff. So we continue to do what we are doing. But if one does want to do a wash of the capsular bag, I think a higher volume, lesser concentration would work better.
There's a question on the YouTube channel that's for Dr. Harpriya, and I think probably not related to this, but they want to know that do you, for one-eyed patients, would you do a conjunctival swab or you will not do? I think that is a question which everybody will ask.
We have stopped it. Yeah, we used to do it earlier in the past. Now we don't do any swab for any patient. Unless
Anybody,
yeah.
yeah, anybody does conjunctival swabs for one-eyed patients.
No.
I think that practice has completely stopped. And uh,
Um,
so when we did a survey from the All India Ophthalmological Society and we published it in Indian Journal of Ophthalmology also, only about one third of the patients, one third of the surgeons were using intracameral moxiflox and two-third were not using it. And surprisingly, a lot of people were giving systemic antibiotics as well, which probably have no role, almost to the tune of 30%. So we had the practice patterns that we showed in our part of the world are a little different from the practice patterns which are there in the Western world.
I just have one query that, there are a couple of articles on double preparation by betadine. So do you follow that, Haripriya?
Yes. Yeah, we do. So we do apply that. I think extremely important that we have good evidence to show the effect of powder and iodine. So we do apply powder and iodine on the adnexa 10% and the conjunctival cul-de-sac 5%, once in the block room and once again on the operating room table with 3-minute contact time.
I think that will also help in the COVID times,
Yeah.
because povidone iodine is going to
Only
kill the
thing,
virus.
the only problem with povidone iodine can be if it has been there for long, it does reduce your visibility during retinal surgery at least.
Yeah.
So I've had situations where I've had compromised visualization.
So cases planned for phaco-vitrectomies, we also do quite a lot of them. And I prefer to limit it only for just 3 minutes. In cataract cases, it doesn't really matter, but I mean, of course, it should not be more than that. But many a time, epithelium has to be peeled off. So that is another new consideration that comes in.
Even with peeling of the epithelium, the visibility does not remain.
I mean, it improves. It improves than what it was before. David, how have you changed your cataract surgery pattern in the COVID times? I think many people would be interested in knowing, though it is not directly related to what we're talking today.
Yeah, I argued that we don't need to routinely test people because we don't believe there's aerosolization. Actually, in JCRS, I should appear online almost this week, is a study from Dr. Vasavada's group. And it was interesting because they were able to use an imaging study to look at forward air transmission from patients in an eye clinic as well as in an eye OR. And, obviously masks help, the slit lamp shield helps, ventilation helps. But the one thing that they did show is that even with the tight mask, there was leakage across the top of the mask that you could really reduce by putting tape across the top of the masks. So it appears that that simple, inexpensive thing, taping the bridge of the mask, does help. And so we've been doing that both in the office and in the operating room. We used to not pull the mask up over the nose because we didn't want to get the povidone iodine in the patient's mask. But now we tape it and we just, don't prep onto the mask. The only other thing that I've done differently is we've kind of eliminated the first post-op day visit unless usually there's a toric lens, which I usually like to check. And that's cut down a lot on the crowding and the visits. And we just do a telehealth checkup. We're probably missing a few high pressures, but we haven't seen any complications of that yet. We're trying a few, I'm certainly doing a few patients, same day sequential, immediately sequential, if it looks like it's just tough to get them in and so forth. So those are sort of the few things we've done differently.
As regards mask, what we have noticed is initially I was using the taping, but now we use a half-piece face respirator from 3M, which looks like a gas mask with a P100 changeable cartridges, which last for about 30 hours. So that gives absolute air tightness, and there is no fogging. So I'm very sure that I'm not breathing in any of the air that is exhaled by the patient. So that is only for the operation theater. Outside, of course, it is the N95 mask.
Yeah, yeah. But I think this is important for your waiting room, for everything. There's so many patients passing through there. And of course, we all require a mask. But putting that tape across, the other benefit is the patient isn't pulling their mask down all the time while they're talking. And then the other is they're not breathing on your hand and your lenses, which you're holding up, and they don't fog up. So it's something that's very simple. And as I said, these imaging studies that were done at Dr. Vasavada's group were very convincing.
There's one question for you, Dr. Harpriya. Do you autoclave the Oromex bottles? Somebody is asking.
We don't have to, but we do autoclave the Oromox bottles because we use the bottles for more than one patient. So it comes as 1 ml vial, and we inject about 0.1 ml each patient. So we draw it in the scrub nurse would draw the drug, so we have it on the table. So we do autoclave them, yes.
Okay.
But you don't have to. It comes in a sterile pouch.
And will it replace the pre-operative antibiotics? I mean, how often are we all still giving pre-operative antibiotics, and whether it is at day 3 or at day 1 or on the day of the surgery? So Harpriya, what is the practice at Arvind?
Yeah, so we actually haven't changed our topical antibiotic regime. So we give ofloxacin 1 day prior and 15 days after surgery, and we continue to doing it because many of our patients, some of them would have some infection of the ocular nexa, they may have some MGDs or mebomytis. So we just want to use this as prophylaxis as well. And this one bottle which they buy, they will continue to use it twice a day for about 10 to 15 days after surgery.
How about you, David?
So I, in the past year, have stopped using antibiotic. And it's mostly based on a study from the Northern California Kaiser Group. This is, again, a large system of clinics that they standardized this. And this is retrospective data, but they found that adding topical made no difference. So again, it's purely anecdotal if I was to do it, but this was, again, sort of a big data approach. So based on that, I just do the intracameral moxifloxacin.
Is it likely to have any medical legal implications not using pre-op antibiotics, though we know it is not really necessary?
Well, I would argue that, you have to look at the literature. So I think that this Kaiser study that's been published, Shorstein is the lead author, is really that, and the PPP, which says that the evidence is really basically for intracameral. There is no evidence that topical does anything. So I think as long as you're doing that, I do think you should do one, or you should do at least one. And but so far, I think we're going to be. I think it's very defensible.
Chitra, how about you? What is the practice at Eye Foundation?
Yeah, we routinely use intracameral Moxiflox for our patients for easily over 5 years. We've been using it, and we are completely convinced that that's the only way to go. And as far as the topical antibiotics is concerned, we do give, actually we start them 2 to 3 days before, as and when they come for the surgery, and continue it for a week post-op. Although we are truly not convinced, but as Haripriya says, that there is some kind of a borderline lid inflammation or meibomitis in these eyes, so it should have a protective role.
So, Dr. Savitri Sharma, ma'am, what is the practice at LBPI?
We don't use pre-operative
Yeah.
antibiotics.
Okay, so less and less people are using pre-operative antibiotics. Again, we continue to use. Rajesh, would you like to tell about the RP center practice?
Yeah, we do use pre-operative antibiotics. We start 3 days before. I mean, that's how it works. Like the patient comes to the OPD and then he's posted in the OT. So the gap between OPD and OT is like that. You started on that day, second day, and then third day is the OT. So it's probably 2 days before the surgery we start, and we continue for 2 weeks or 3 weeks, depending upon the patient.
So, Harpriya,
Can I ask a question to Haripriya?
Yes, ma'am.
Yeah, actually, did you say that you autoclave the
Yes,
moxifloxacin?
yes, we do.
But autoclaving is supposed to, I think antibiotics are heat labile.
No, we gas sterilize them. So we
Oh, you gas sterilize, but you said autoclave. Yeah.
I'm sorry, yes, gas.
Gas
So we
sterilize.
EPO them.
Yeah. So the question was autoclave, but we have
but what I meant was
yeah. Okay.
One more question, Harpriya, for you. You said you use pre-operatively Oflox and then intracameral Moxiflox. So why do you want to, change two drugs, and why not use the same drug, pre and intra? I mean, you're using Moxiflox, so I mean, I don't know what is the rationale. So somebody has asked this.
Actually, it's I mean, as we know, the chance of having resistance to an antibiotic is more with topical medication than intracameral. Intracameral with a small bolus and a small concentration. So we want to and Moxi as the established drug, it's been time tested, and that's what we use intracamerally. But topically, we try to reserve the Vigamox and the Moxi for patients who, where we really need it, like in endophthalmitis, then there we shift to Moxifloxacin. But we have been using Ofloxacin for many years now, and that seems to be working well for us. So we are trying to save the Moxi instead of using it in a large scale of patients and increasing the chance of resistance.
My impression that ofloxacin is less burning, causes less burning and stinging than moxifloxacin.
Okay, I didn't know that.
Hyperemia also, Moxiflox causes a little bit of congestion.